Hello and welcome to this webinar on the new CAT VGel Advanced Airway devices. We're going to talk a little bit about what's new with the VGel Advanced devices and why that's important. And then I'm going to go through how I fit VGel Advanced Airway devices into my feline anaesthesia. My name is Ivan Krotas. I am a companion animal veterinary surgeon in the UK, and I'm one of the anaesthesia consultants to Docs in Events Limited. In this webinar then we're going to go through a little bit about the history and the background of VGel devices, where they came from. We're going to work through a little bit of endotracheal intubation in cats, and I'm going to go through some of the things that you may not have come across with intubation before. And then, as we said before, what's new with the VGel Advanced devices and how we fit those in to anaesthesia protocols. What is a VGel airway device then? Well, VGel airway devices are species-specific veterinary devices, and they are supraglottic airway devices. Now, when you are anaesthetising a patient, you have three options for managing the airway. In other words, connecting your anaesthetic circuit to your patient. A face mask, very commonly used. They're sitting over the mouth and nose, and you're trying to form an airway seal over the mouth and nose. Very simple, very easy to use, quite difficult to get wrong, but the main issue with face masks is that they leak, and also that you're not giving any protection to the upper airway. So any mucus in the mouth, any mucus in the nose could block the airway quite easily. And of course, with leakage, we are using volatile anaesthetic agents. When you have leakage around that face mask, your staff are breathing in volatile anaesthetic agents, which does give you a health and safety problem over a long period of time. Supraglottic airway devices sit over or around the larynx, and they form their airway seal deeper within the airway around the larynx itself. You may have come across these in human anaesthesia. There are many different designs of supraglottic airway devices. One of those is known as a laryngeal mask airway. And then endotracheal tubes that many of us use all the time, and they're placed right down through the larynx, forcing their way down into the trachea, and they're forming their airway seal much deeper down within the airway. Human anaesthesia, supraglottic airway devices are very commonly used, and the reason for that is to reduce the trauma that's associated with endotracheal intubation, and that's both the risk of trauma and also the pain and discomfort associated with intubation. In order for a supraglottic airway device to work, it actually has to match the anatomy of the upper airway, so the shape of the pharynx and the shape of the larynx, in order for it to work. And VGel devices have been designed to fit various veterinary species. So you have a different shape one for a rabbit, different one shape for a cat, dog, horse, etc. And as it stands, VGel supraglottic airway devices are the only ones that have been designed for the veterinary species. The background of VGel then. Well, VGel was designed by Dr. Nasir, who is also the inventor of the human iGel supraglottic airway device. And you can see here an iGel in position in the cutaway view, and that large green soft cushion at the base near the larynx, that's moulding and matching up to the laryngeal anatomy, the laryngeal framework, in order to create an airway seal. The cat and the rabbit VGels were launched in 2012. Here you can see a cat device, obviously very different shape to the human devices. This is what we were saying. They're species specific. They have to match the upper airway anatomy. And at the base you can see a rabbit VGel device, broadly the same structure as the cat, but obviously very different in the detail in order to fit into the rabbit upper airway. There's continuous research work going on in the background with the VGel devices, and that's resulting in the VGel Advanced devices for both cats and rabbits, and also other work in other species to develop supraglottic airway devices for a variety of veterinary species. Complications then from endotracheal tube use. We're all intubating cats. It's a very common technique, but what can go wrong? The commonest one, and one I'm sure we've all seen, is upper airway trauma related to feline laryngeal anatomy. The larynx is delicate, it's easily damaged. You can see laryngeal spasm, and that's very, very common indeed. You may be seeing or hearing spasm on intubation as the larynx reacts to the tube, touching the arytenoid cartilages or going through the larynx and touching the trachea further down. We see laryngeal or tracheal edema. That is more difficult to recognise. It very frequently occurs post-extubation, so that can be in the recovery period where there is nothing maintaining the airway, and that of course makes it far more dangerous. We do see either laryngeal or tracheal tears, so laryngeal tears often as a result of poor intubation technique or using a tube that's too large for the larynx. Tracheal tears can happen at the point of intubation as the sharp tip of the tube traumatises the laryngeal mucosa, or you can see that as a result of overinflation of the cuff, and that can cut the blood supply to the tracheal mucosa, and then you get necrosis of the trachea happening over a period of time and rupture as a consequence of that. The other thing to think about is that whenever we're using a tube in cats, an endotracheal tube in cats, there are unavoidable consequences. And the major one to think about is the tracheal epithelial trauma that happens when you touch the tracheal mucosa. So this is a study that was done, in fact this was a study that was done in dogs, but it's equally applicable to all mammalian species. The mucosa of the trachea is a ciliated epithelial mucosa, so you've got these little cilia that beat and they waft a layer of mucus from the depths of the lungs up to the top, and they move bacteria and debris out of the lungs very effectively. That's called the mucociliary escalator. When anything touches those cilia, the cilia are amputated, they're removed from the surface of the mucosa. You're not actually removing the mucosal cells themselves, but it takes time for those cilia to grow back. And in that time while they're growing back, the mucociliary escalator is disrupted. And that means that bacteria and debris cannot be effectively removed from the depths of the lungs. That's going to mean that you've got an increased risk for your patient if there's any lower respiratory infection going on or any contamination of that air. You'll also have an issue with airway narrowing. Obviously, by definition, if you're placing an endotracheal tube into a cat's trachea, you have to narrow the airway. So the tube has to fit into the trachea. The tube itself has a wall thickness. That means that the airway that cat has to breathe through is narrower than the original trachea would have been. There's an inverse to the fourth power relationship between diameter and resistance. So broadly speaking, if you halve the airway diameter, the airway resistance is going to go up 16 times. So it's making it 16 times harder for your patient to breathe. And that's why using the widest possible endotracheal tube is useful. But you also have to consider that a wider tube is going to create more contact between the tube and the tracheal mucosa, so potentially more trauma, and it's certainly going to create more contact between the tube and the larynx, and that's going to give you also more laryngeal trauma, more risk, more discomfort, more pain for your patient. Endotracheal tubes are more difficult to place than supraglottic airway devices. You have to be more specific about where you're putting the tube. You have to observe using a laryngoscope and make sure that you're not traumatizing the larynx on the way down, and that increases the risk of hypoxia or hypercapnia as a result of that longer induction period. And certainly something that we've seen a lot with the original V-gels. When you compare endotracheal intubation to supraglottic airway device or V-gel anaesthesia, the patients having an endotracheal tube have a reduced quality of recovery. You hear more stridor, and that is the result of what the tube is doing to the larynx and the trachea. The V-gel advanced devices have been based on the successful original V-gel for cats, but we've taken opinions from clinicians around the world to create the new advanced devices. Now the major change has been in the pharyngeal section. A new thin-walled soft seal wraps around the larynx like a curtain, and that does a number of different things. You get still an easy insertion, you get an increased stability, so there's less likelihood of the VGL displacing during use, and you get a real upgrade to the airway seal. This airway seal, in my experience, will seal at airway pressures between 15 and 25 centimetres of water, and that makes it suitable for IPPV, so that might be squeezing the rebreathing bag, or mechanical ventilation, as you might see in referral practice or more advanced anaesthesia, but as well as normal spontaneous respiration, where your patient is just breathing for themselves, as you would see in general practice. The oral section has been reduced in bulk. Now the reason for that was to give more access for dental surgery, but what we've done is created a shape that maintains that nice wide airway diameter all the way through the device, so you're still not making it harder for your patient to breathe. A new single-use presentation that makes it cheaper to keep different sizes in stock, but it's also been done so that you eliminate the risk of cross-contamination, and of course there are quite a lot of viruses and bacteria that exist in the mouth and pharynx of cats that can be passed on to the next patient. And a new low dead space connector in the smaller sizes of the feline V-gels improves safety, but again we've looked at airway resistance and we've maintained an airway all the way through the device that's either as wide or wider than the trachea. Here you can see a video. This is taken with a bronchoscope through one of the V-gel advanced devices, and you can see the bronchoscope going into the pharyngeal section in a moment, and you'll be able to see that thin curtain wall seal wrapping around the larynx and the arytenoid cartilages of the larynx sitting unaffected within the middle of the airway and the epiglottis untouched. So you can see here the arytenoid cartilages moving with each breath, and then the epiglottis coming rostrally towards you. And this is the reason why the recovery is good, because when that patient recovers from anaesthesia, nothing has been touching or resting on those arytenoid cartilages. There's no risk of traumatizing those, and certainly nothing's been touching the trachea itself. That's left completely unaffected. Here you can see an image of a V-gel advanced device for cats. You've got this thin-walled flexible seal, and that's there to give you that improved seal performance and improved stability, meaning you can ventilate your patient throughout anaesthesia if you want to. We've retained the esophageal section from the original V-gel, and the reason that's there, if your patient refluxes during anaesthesia, it presents a barrier to reflux fluid, and that reduces the risk of reflux fluid moving through into the pharynx and potentially accessing the larynx and the airway. You've got this reduced diameter oral section, so the device is slimmer than the original V-gel, but you've still got that nice wide airway that's reducing the airway resistance throughout the device. In the smaller feline devices, we've got the new low dead space connector. That makes feline anaesthesia in smaller patients safer, but again, we're maintaining that airway diameter through the device. A variety of different securing points, slightly different to the original V-gel. You'll notice a little difference in shape there. That's been done to improve oral access and to make dentistry easier. And here you can see a cross-sectional view, so you can see where that V-gel is sitting. It's sitting within the pharynx itself, with the esophageal tip sitting just within the proximal esophagus, and then the larynx sitting within the V-gel itself, as you can see in that video. So why does this matter? Why have we done all of these things? Well, anaesthesia complications in cats are frequently related to airway issues. There's a large body of evidence now showing that. The percentage of patients that encounter airway complications are significant. It's something that you're going to see on a regular basis. We know that intubation causes laryngeal and tracheal mucosal trauma. That's been very thoroughly proved, and all of us that anaesthetise cats on a regular basis will hear upper airway stridor related to that trauma. It's not that it's fatal in every case, but it certainly does increase the risk involved with feline anaesthesia. We know from the work that's been done that both the original VGel devices and now the VGel advanced devices for cats allow you to maintain an airway without touching the larynx or trachea. So it's a way of delivering fresh gas and volatile anaesthetic agents without the additional risks involved with intubation. VGel protects the upper airway from obstruction, and the VGel advanced devices now allow you to ventilate your patient without leakage. You don't have a structure, an endotracheal tube, that's going right through the larynx and down into the trachea, and you do have to take that into account when you're anaesthetising patients. But as the work done in humans shows, there's no reason not to anaesthetise patients with a supraglottic airway device. The new VGel advanced devices have a number of different changes. You'll notice that the original inflatable seal adjuster from the standard VGels has now been replaced with this flexible seal edge, and that automatically adjusts for different pharyngeal sizes, and that will give you a much better airway seal than you were getting with the inflatable seal adjuster, and of course it's much easier to use. You don't have another thing to worry about. We've got this reduced dead space for the smaller sizes of VGel while still maintaining an airway that's wider than the trachea. And you'll notice with the smaller sizes of VGel Advanced that they have added material within the airway connector itself. We've got this new single-use design, as we mentioned before, and that makes it easier to manage the risk of cross-infection with your patients. And we've got all these optimizations for dentistry. Although many of us, myself included, used the original VGels for dentistry and we found them very useful, the VGel advanced devices give you more space to work with. I've made two changes with my airway practice over the years. I've changed originally from using endotracheal tubes with all of my feline patients to the original VGel, and now to the VGel advanced devices. The original VGel, the things that I saw in clinic, definitely better patient comfort in recovery, less stridor, less evidence of upper airway issues. Faster insertion. I never found it particularly time consuming to place an endotracheal tube, but it certainly takes much longer than placing a VGel. And if you're looking at repeated procedures in the same patient in a short period of time, the VGels were much less traumatic than you found with an endotracheal tube. And certainly those of us who did things like radiotherapy, where you're wanting to re-anaesthetise that patient over and over again in a short period, found that the VGel devices were very useful. The VGel advanced devices, because they're based on the same science as the original VGels, they've got the same benefits as the original ones. The things that I've seen myself, you've got this large improvement in seal pressure. So you can use VGel advanced devices in both routine general practice anaesthetics, but also more advanced anaesthetics where you're wanting to ventilate at higher seal pressures for longer periods of time. And that improved design for dental surgery, that's quite a big deal. It means that you've got more space to work, you can move instruments around, you can visualize the teeth much more easily, and the device itself is a little more flexible than the original VGels, so you can displace it around the mouth more easily without worrying about displacing it from the airway. So when I'm working with the VGels then, what do I do to fit VGel advanced devices into my day-to-day anaesthetic protocols? Bear in mind, with the improvement in seal pressure now, VGel can be used as a replacement for an endotracheal tube in most feline anaesthesia procedures. I would say the exceptions would be procedures where you might want pharyngeal access, or where you might want to be doing single lung ventilation with more advanced thoracic procedures. In those kind of cases, you are going to want to place an endotracheal tube, because the VGel is not going to work for you. You're not going to get the access you need for that kind of specific requirement. First thing I would think about is the human factors in anaesthesia. the anaesthetists themselves, and this is a very useful quote indeed, you need to be thinking about your anaesthesia in much the same way, whether you're using face masks or endotracheal tubes or V-gel anaesthetic devices. Good starting point with anaesthesia is thinking about how you construct protocols. Each drug can affect 3 different parts of an anaesthetic. So some drugs will be good anaesthetic agents, some drugs will be good analgesic agents, and some drugs will be good muscle relaxant agents. I've put muscle relaxation in brackets there because it's uncommon in veterinary anaesthesia to use muscle relaxants, because you have to ventilate to a much higher level, you have to monitor to a much higher level, and few of us, at least in general practice, routinely use muscle relaxants, but nonetheless, it's worth considering it. So drugs, for instance, like isoflurane, sevoflurane, are good anaesthesia agents, but poor analgesic agents. And what you want to be doing is thinking about, do I have an anaesthesia problem or do I have an analgesia problem, and pick drugs that have an appropriate function. Preoperative preparation with cats then. You do want to think about pre-existing disease. So in an older patient, this might be pre-existing renal or hepatic disease. In a younger patient, this might be respiratory disease that this patient has had, or disease that's causing pain that may be affecting your anaesthesia. General health, the ASA grade that we hopefully all use, correlates with underlying health very strongly and age less strongly. So pre-existing diseases and underlying problems are things that you should be considering at an early stage of your anaesthesia before you're starting to administer drugs. Synthetic feline facial pheromones are very useful in terms of reducing stress. Now, of course, stress should be considered, and I think about it almost as a pre-existing disease. If your patient is stressed, it's going to increase heart rate, it's going to increase adrenaline release. Adrenaline does sensitize the myocardium to arrhythmia, it does increase your anaesthetic risk, and of course it makes life rather unpleasant for your patient. So you should be thinking about things with feline anaesthesia that reduce stress from the earliest point when that patient is handled, coming to your practice, being transported to your practice, how it's handled, how it's housed within your practice. Calm handling, super important, can't be overstressed. If your patients are fighting, it's because they're terrified in almost every case, rather than because they're aggressive. And if you can minimize fear, you make life easier and safer for your patient, and also easier and safer for yourselves. You might want to think about behavioural modifying chemicals, behavioural modifying drugs, preoperative sedation, oral sedations before particularly stressed patients arrive at the practice. These are all things that can be built into your anaesthesia protocols. You should be thinking about hypothermia. So feline patients have a high surface area to body mass ratio. They lose heat quickly, and particularly they lose heat after they've had pre-medication drugs and they are sedated. Think about your room temperatures, maintaining your room temperatures not too hot, not too cold. Make sure that you're temperature monitoring both your room and then your patient. Think about medical grade warming, that's very, very important. Skin burns are commonly reported as an anaesthetic complication in cats, so you should be using good quality medical grade warming devices that mean that accidental burns are not a possibility. Microwave heated pads, hot water bottles depend on you providing adequate layers of insulation, and it's just too easy to make a mistake, and mistakes are unfortunately very, very common indeed. You should be thinking about temperature monitoring that patient from the time it arrives at the practice, so having a temperature check as the first thing that you do, all the way through your pre-medication period, into your induction period, maintenance and recovery. You should never be letting your patient get cold and then try to warm them up. You want to identify temperature issues at a very, very early stage and manage that. Pre-oxygenation is important in cats and all other mammals. Now in humans it's been intensively studied. 3 minutes of spontaneous oxygen breathing gives you a long period of protection against oxygen desaturation. Giving that patient deep breaths over a shorter period of time allows a comparable increase in protection. Now, what you need to be thinking about here, fresh oxygen from your anaesthetic machine will often smell bad. It'll have a taint of volatile anaesthetic agents. It's going to increase the stress on your patient. So it's not that you shouldn't pre-oxygenate your patients, you should. It gives protection in the early stage of anaesthesia, which is when many problems happen. But if you have a particularly stressy animal, you may want to be delivering oxygen in a different way. You could potentially be delivering oxygen to your patient after sedation or pre-medication has been administered, so that patient is less prone to the effects of stress. So you've got options of oxygen tents, face masks, or adapted Elizabethan collars. So the Elizabethan collar with a film over the front and an oxygen feed coming in at the back of the collar, or assisted ventilation under deeper sedation, and that's comparable to this 8 deep breaths over 60 seconds that paper above was doing. But do think about administering oxygen to your patients prior to induction. It does improve safety in that critical period. What constitutes a good induction then? Well, there are many drug protocols for feline anaesthesia, and all of those drug protocols have good points and bad points. It's a question of what are you trying to achieve? You need to be thinking about providing a pre-medication that has appropriate sedation and analgesia components to the procedure. And that means that a short radiographic procedure, or maybe an ultrasonic procedure where you don't need much in the way of analgesia, you just need sedation to reduce stress or to relax your patient, that's going to be very different to pre-medication for abdominal or thoracic surgery. So you need to think about what problems the procedure is going to throw up, and then put drugs into your pre-medication that are appropriate to that. You need to think about stress and fear, particularly with feline patients. They're very, very prone to it, and use a combination of both pharmaceutical and non-pharmaceutical agents. And I'm saying non-pharmaceutical agents in terms of fear-free handling, fear-free housing, not housing your cats next to your dogs, keeping noisy dogs away from your feline patients to reduce the stress that they're encountering in the early stage of the day. Try and avoid painful delivery of drugs. So if you have the choice of an intravenous administration of an agent and an intramuscular administration of an agent, then think about the intravenous agent being less painful and superior in terms of reducing pain and reducing stress. Obviously, if an intravenous administration increases risk, then you have to take that into account. Communication and checklists, very, very important. Checklists on their own, in my personal opinion, do not improve anaesthesia safety unless they are accompanied by an improvement in culture in the anaesthetic team. And culture for me would be that the anaesthesia and surgical team are communicating and talking to each other, so that everyone in the room knows what's going on, knows why it's happening, knows something of the background and history of that patient, so that every person in the team knows what might happen next. And then when there's a problem, everyone's working together and working quickly. In a team like that, checklists are extremely useful and help prevent you making mistakes. If you don't accompany checklists with a good anaesthetic room culture, then in my experience they're ineffective, and in fact may make you feel that you have safety where you don't. And checklists can be ignored very effectively. So think about creating a culture where communication is encouraged between different team members, and then back that culture up with checklists so that nothing is missed. Think about a short period of pre-oxygenation as we've discussed, and then you want a calm, controlled induction with continuous monitoring where your team is concentrating on your patient and not chatting about other things. So it's absolute concentration on that induction procedure. Think about patient positioning. Positioning patients so that there's pressure on the chest is not going to be helpful. Positioning patients so that they're tilted downwards, so that the abdominal contents are resting on the diaphragm, is going to make it more difficult for your patient to breathe. If your surgeon is resting their hand on the cat's chest while they're talking to you, get them to move their hand. So think about things that make it easier for your patient to breathe and ventilate. And the final endpoint of induction, you're trying to get to an appropriate plane of anaesthesia that's appropriate to what's coming next. It's stable, you haven't got the depth of anaesthesia changing all over the place, and you're ventilating your patient if you're seeing apnea. Conversely, what would I consider a bad induction? Again, this has got nothing to do with the drugs that you choose, this is how you manage that induction. I don't like anaesthesia recipes. It's a cat, therefore this is what we do. You're not considering the individual factors. You're not thinking about the fact that this patient responds very badly to pain. This patient is extremely fearful and might benefit from some extra sedation in the preoperative period. So I like to see people looking at the individual patient, looking at the protocol, looking at the analgesia in particular, and picking appropriate agents for that animal. It's not difficult to do, it's not time consuming to do, and you will get into the swing of it very, very quickly. I don't like situations where people walk into the operating theatre or walk into the anaesthetic induction area, put the patient on the table, and then just anaesthetise them with no discussion. People's heads are not in the game, nobody knows what's going on next, nobody's concentrating, and if something goes wrong, you waste vital seconds where everyone realises there's a problem before anyone starts to fix it. If you have a pain-free route, use it. There is no point in causing unnecessary pain. It's unpleasant for the cat, it's difficult for your staff, and it's just unpleasant for everyone. So think about what is the least painful and least stressful way that I could be administering this drug. And definitely avoid high stress or forceful restraint techniques. In most cases, there are alternatives if we stop and think and just take some time, and particularly if we plan before you start that anaesthesia process in the first place. Most high stress and forceful restraint techniques happen because people didn't think it through properly beforehand. Let's think about laryngeal spasm. Well, VGel and VGel advanced devices, in my experience, reduce the risk of laryngeal spasm. Let's think about why that is. Well, common causes of laryngeal spasm are most frequently intubation related. And of course, with the VGels, as you saw in that video, we're not resting on the larynx in the first place. However, if you touch the pharynx or soft palate or the laryngeal structures, anything towards the back of the mouth and the upper airway, the larynx will activate this laryngospasm as a protective mechanism. And of course, both VGel and VGel advanced devices do touch the pharynx and the soft palate as they move through, so laryngeal spasm is something that we should be considering. The third thing to think about is sympathetic stimulation during anaesthesia or pain, as you might think about it. That is something to consider with both a VGel or VGel advanced anaesthetic and also an intubated anaesthetic. When we're thinking about those non-intubation causes of laryngeal spasm, so causes that you might potentially see during a VGel advanced anaesthesia. If you touch pharyngeal structures when the patient is not adequately anaesthetised, you can see a laryngeal spasm, whatever airway device you're using. If you have a patient that's inadequately anaesthetised and you cause pain or sympathetic stimulation during that anaesthetic, you could see a laryngeal spasm. What do you do about it? Well, compared to an intubation trauma spasm, this is much easier to manage. Intubation trauma spasms are caused as the larynx rams down onto the arytenoid cartilage, so either causing physical trauma or sometimes dislocation of some of the laryngeal cartilages, and the larynx slams shut. You often get mucosal edema as a result of that trauma as well. It's all much more serious. With the causes of laryngeal spasm listed above there, that touching pharyngeal structures or pain, it's much more of a transient spasm. It's a flutter. It gives you a quite specific upper airway noise. What do you do about it? Well, you resolve the causes. So if the cause is a V-gel going into the upper airway, or around the pharynx, I should say, at an insufficiently deep plane of anaesthesia, you remove the V-gel, a couple of breaths of oxygen through a face mask, and you deepen the plane of anaesthesia, generally with an intravenous agent. If that laryngeal spasm is happening during the maintenance phase of anaesthesia, in the vast majority of cases, that's going to be because you're doing something painful under the anaesthetic and the anaesthesia is not deep enough, and you would deepen the plane of anaesthesia and you would see that spasm resolving in a very short period of time, normally within about a 5 to 10 second period. So think about the plane of anaesthesia. When I've seen laryngeal spasms happening during both V-gel and V-gel advanced anaesthetic procedures, it's generally because the plane of anaesthetic is insufficiently deep, and you just need to be thinking about monitoring and maintaining that plane of anaesthesia. Think about lubrication on insertion as well. Obviously, the pharynx is still delicate. The V-gel is very smooth and very streamlined, so it will sit into place well. But whenever you're inserting anything into the pharynx or around the upper airway, it should be lubricated. Vet Lube is made by Doxinevent, is a very nice water-based lubricant spray. The nice thing about the Vet Lube is that it's very quick and easy to cover the large area of the V-gel. You do need to make sure that when you're lubricating a V-gel or a V-gel advanced device, that you ensure that the airway channel itself is not being blocked by lubricant, as you would do if you're lubricating an endotracheal tube. The workflow for using V-gel then. There is more detail on the Doxinevent website with some videos up there as well, but essentially what you do: controlled induction, preoperative oxygenation, as we were discussing. You want to make sure that after induction you check the mouth and remove any debris that's there. It's not common to see debris in a cat's mouth if you start them before the anaesthetic, but it does happen, and you don't want to be pushing food material down into the pharynx and potentially into the larynx and the upper airway. You want to choose the appropriate V-gel size, lubricate it just before you insert it. Apply lidocaine, an appropriate dose of spray lidocaine, to the upper airway, precisely as you would do if you were doing an endotracheal intubation procedure. You then need to insert the V-gel into the pharynx. On the user guide for the V-gel, it's got a whole variety of images showing you precisely how to do it, but you need to make sure that the airway channel itself is pointing ventrally. You pull the tongue gently out, you rest the V-gel flat on the tongue, and then just insert it gently. You'll feel a very slight stop as it moves past the pharyngeal arch at the back of the mouth, and then it'll get easier to move through it, and you'll feel a slight drop as it sits down into the pharynx. You then always check the placement of your V-gel, again precisely as you would do with an endotracheal tube. You've placed your tube. What are you going to do? You're going to squeeze your rebreathing bag, and you're going to check that the cat's chest moves. Then you're going to watch the cat's chest moving and check that the rebreathing bag moves. Well, we're going to do exactly the same with the V-gel. So you place your device, you squeeze the rebreathing bag, you make sure the chest moves, you watch the chest move, you check that the rebreathing bag is moved. You then secure the V-gel using the bandage tie, again very much as you do for an endotracheal tube, round the V-gel itself and then round the back of the ears. It's much easier securing a V-gel because it's got those little grip points on it that stop your bandage tie slipping, so you should find it more secure. I always use the D-grips that, again, Doxinevent make. They're very, very useful to stop the circuit pulling and displacing the V-gel out. And what I normally do is secure the V-gel in place, position my patient, and then I attach the D-grip and the circuit in place at that point. and then I attach my capnograph and I make sure that I'm getting capnograph traces. A capnograph trace or a normal capnograph trace on my capnograph tells me that the V-gel is in the correct position. Maintenance phase of anaesthetic then. You can see a V-gel set up here in our anaesthesia area in my clinic. You can see the V-gel coming out of the mouth, and they normally come out of the mouth at an angle of about 40-45 degrees or so. The D-grip is supporting the circuit so that the angle of the V-gel is maintained about 40 to 45 degree angle, and that means it's sitting naturally within the mouth and pharynx and not displacing any of the upper airway structures. You can see my capnograph in place, you can see pulse oximeter in place, and you can see that I'm using the D-grip to support and tidy the cables for my monitors. On the right hand side there you can see my small animal ventilator, and I do try and ventilate most of my small patients. It makes things much easier as an anaesthetist. When you're thinking about monitoring, these are the three things that I would think about, and I would think about these whatever airway management technique I was using. So number one important thing is full and undivided attention from the anaesthetist. The anaesthetist should, in the ideal world, be anaesthetising and nothing else. You should be thinking about combining both manual skills and electronic monitoring. It's not true to say that manual skills on their own give you absolute safety. There are things that you just cannot tell without electronic monitors. And you should always think about reacting to small changes rather than waiting for changes to get big and dangerous. So try and react early to complications. Respiratory monitoring, I would say, is absolutely fundamental for feline anaesthesia. And the reasons for that, well, every drug we're using is a cardiorespiratory suppressant. Everything. Hyperventilation and hypercapnia are common complications in CAPS. This is not a rare, once-in-a-blue moon complication. This is something that we're seeing all the time, but perhaps we're not recognising it as often as we should, and particularly so in general practice. So that means that you need to be monitoring the respiratory system regardless of the airway management technique that you're using. Things that I would think about, you want to be monitoring your respiratory rate and depth, which I'm sure we're all doing, but you should also be monitoring your respiratory effectiveness. You can move your chest without exchanging gas. So think about things like monitoring thoracic movement and rebreathing bag movement at the same time. And that's telling you a number of things. It's telling you respiratory rate, as we're always doing, but it's telling you about how effectively that patient is shifting gas. It's telling you how effectively your airway management tool is working. Is there a kink in your tube? Is there mucus blocking? Is your anaesthetic circuit working? Do you have oxygen flowing? A whole bunch of different things. Think about ventilating your patient perhaps more frequently than we might have done in the past. So ventilation is something that helps your patient out. Certain things that we do with the patients, like using troughs or compressing the chest or restraining limbs in particular positions for radiography, they can all make it quite hard for the patient to breathe. And that means that that patient may be not excreting carbon dioxide as well as they should, and that can build up anaesthetic risk very, very quickly. Of course, when you ventilate your patient, you're also immediately checking and feeling how well your airway management tool is working. So is your endotracheal tube in the right place? Is it kinked? Is it blocked? Is your V-gel device working effectively? That sort of thing. And of course, what do we want to be doing about electronic monitoring? Well, my minimum recommended monitoring for any companion animal anaesthesia procedure will be a pulse oximeter and a capnograph. That will be the least I'd want to be using on anything. And of the two, I think that capnography is more important than pulse oximetry. Pulse oximetry is relatively easily tricked. It's quite hard to trick a capnograph. They give you better information and more immediate information. And a capnograph is essential to understand how effectively the respiratory system is working, how effectively it's excreting CO2 from the body. You can then alter the rate and depth of your ventilation according to the capnograph, or of course if you have a blood gas analyzer, you can use blood gas analysis to measure how well the respiratory system is excreting CO2 from the body. It will give you advanced warning of respiratory problems, and don't forget, one of the respiratory problems is the fact that we have an anaesthetised patient. So anaesthetised patients don't have an effective respiratory system. The respiratory system is being suppressed, and CO2 can build up gradually over time, and that builds up to higher and higher anaesthetic risks. If you know that the CO2 levels are building before those CO2 levels get toxic and start causing problems, it's a very easy thing to do to ventilate your patient and bring those CO2 levels back down again. And of course, if you're not lucky enough to have a ventilator in your clinic, you can squeeze the rebreathing bag and manually ventilate the patient to bring those CO2 levels back down again. And of course, the other monitoring techniques are very important indeed. Temperature monitoring, as we were discussing before, absolutely really important in cats, because they do lose heat very easily, and hypothermia in cats is a common cause of problems, particularly in the anaesthetic recovery period. But use whatever electronic monitors you can. Blood pressure monitoring and ECG monitoring with feline anaesthesia, also very important things. As I say, my minimum recommendation would be pulse oximetry and capnography. So recovery from a V-gel anaesthetic. Well, as you saw in that earlier video, the V-gel advanced design does not rest on the larynx. That seal wraps around the laryngeal framework. And that means that you get a difference in recovery. Certainly from what you were used to with an endotracheal tube, it's broadly similar to what we've experienced with the original V-gels. Don't expect a cough reflex. In my experience, that's quite uncommon. Normally I wait for conscious eye movement or conscious head movement, something like an ear flick if you tickle the ear, or little facial twitches, or the cat just rolling their eyes and looking at you. And sitting up will occur fairly quickly after that, normally within about 10 or 15 seconds or so. The V-gel advanced devices are quite tough. They can handle some bite trauma, and of course they're too large to be inhaled, and that does reduce the stress in that immediate recovery period. So if that patient was to wake up very quickly and bite down on the V-gel, it's unlikely that they'd cut it in half, and it's certainly impossible for them to inhale it. But having said that, I wouldn't suggest that you leave a V-gel in the mouth of a conscious patient. They're quite likely to panic or stress because of this thing that's in place in their pharynx. Now, the only exception to that would be if you had a patient that was having a slow recovery, either by accident or by design, and you wanted to leave the V-gel in for a longer period and ventilate or supply pure oxygen. It would be a reasonable thing to do if the patient was not panicking or stressing and there was no sign of any transient laryngeal spasm as the result of having the V-gel in the pharynx. Then under constant supervision, it's something that I would consider to be acceptable, and you then remove that V-gel when the patient starts reacting to it. The other thing to consider is sometimes if you have a very tightly fitting V-gel, if you've been going for a very strong airway seal, sometimes it's useful to slightly rotate the V-gel counterclockwise or clockwise just by about 5 or 10 degrees before you remove it. There's quite a strong lock of the V-gel behind the base of the tongue to help stabilize it in place, and that small rotation movement does tend to help unlock it and make it easier for you to remove. With the V-gel advanced, you've got those recovery advantages. So intubation bypasses the larynx, so you're going all the way past it, down into the trachea, and don't forget that the tube is pushing the epiglottis ventrally onto the floor of the pharynx into an anatomically unusual position. And of course, in recovery, the larynx then has to recover its normal function. The arytenoid cartilages have to start to move normally. The epiglottis has to raise back into a normal position. With the V-gel advanced devices, the larynx and epiglottis are functioning, the arytenoid cartilages are moving as normal throughout the anaesthetic. Now, of course, that's not something that we're used to considering with an intubated anaesthetic. We've all grown up with those, that's all normal to us. But one of the differences that we see in recovery is the difference from the larynx not having to make any changes to its function between the maintenance state and the recovery state. We see a quicker return to normal breathing and no coughing related to endotracheal tube use. So it's much simpler for those patients to return to normal respiration. And I see improved comfort in the recovery period, and what my nurses are seeing is a faster return to eating or to normal appetite compared to endotracheal tubes. We've gone through the technical advantages and we'll just summarise them here. I think this is the biggest deal with the new V-Gel advanced devices, the superior airway seal, giving you seal pressures of well over 15 centimetres of water in most cases, and it's quite common for me to get to 25 or 26 centimetres of water seal pressure. And that means that it's appropriate both for general practitioners, where you might be using spontaneous respiration, or advanced practitioners who are ventilating for short or long periods of time. We've got this slimmed down flexible design, so it's making it much easier to use these V-Gel advanced devices for dental procedures. Still fast and easy to place like the original V-Gels. It's though more stable, so it's easier to use. It displaces less easily. You have to make less effort and spend less time thinking about stabilizing them. Just like the original V-Gel, we've got that nice wide airway channel, but we're protecting the patients against the effects of dead space, particularly the smaller cats. And we've got this new single-use design, so it makes it cheaper to hold a larger range of devices and also protects your patients against the risk of cross-infection. So for me, why would I want to reach for V-Gel advanced devices? Of course, I've got the option to use endotracheal tubes, or the original V-Gels, or the V-Gel advanced devices. From a personal perspective, there are two things that I look at in day-to-day clinical practice. It's this reduced trauma. I know what an endotracheal tube does to the larynx and trachea. I know that that mucosal trauma is unavoidable. It's not a question of my technique. It's not a question of my tube size or how well I lubricate the tube. When you touch the laryngeal and tracheal mucosa, you cause damage. And it's nice to be able to use an airway device that allows me to ventilate and maintain an airway effectively without touching the larynx and trachea. And the other thing that I see and my nurses see is this really excellent quality of recovery. And it's very nice to look at a patient and see them recovering smoothly and quickly and comfortably, not having upper airway pain and stridor, and going to eat quickly. So though from a personal perspective, that's why I get a V-Gel advanced device out of the cupboard as my first airway management option of choice for feline patients. Well, thank you very much for staying with us with this webinar. If you go to either the Docs in Event website or the Docs in Event Facebook page, you'll get much more information about what Docs in Event do, the range of devices that they have. There is the user guide that's on there and a range of different videos, frequently asked questions, and you can get all the information you want through there. Thank you very much.